The next talk will be on treatment regimens in neovascular AMD. Dr. AVNINDRA Gupta, please.
Uh, Thank you very much. Uh, Thank you, Dr. Lalit, for having me here. 90% of our AMD patients, if we look at, is what is dry AMD, and rest 10% of the patients are neovascular age-related macular degeneration. Treatment of neovascular age-related macular degeneration can be classified according to the site of lesion. That is, if you have an extrafoveal lesion, then you can treat this lesion with thermal laser and you give a permanent treatment. Type of AMD lesions will decide about what VEGF to use. Like in a normal AMD patient, you need to inject with ranibizumab or bevacizumab. But if you have a patient of PCV or a pachychoroid disease, will require aflibercept or brolucizumab. If you look into the genesis of age-related macular degeneration before 1980, we didn't have treatment. Thermal laser came in 1980s. And in 2000, we shifted in terms of stabilization of vision and we came up with photodynamic therapy. And the major breakthrough was in 2006 when we started about improvement in vision and not stabilization of vision in subfoveal age-related macular degeneration and when anti-VEGF therapy came. And now we are talking about increased durability, reduced treatment burdens, and improved anatomical outcomes. Uh, if we look at the different approaches, we started with the monthly regime, and then we have observe and plan, wait and extend, treat and extend, and PRN, and we'll discuss each of the regime how we go ahead with this. It's important before going for a treatment, you should always recognize extrafoveal lesion. Now, this is one of the patient who came with a decreased vision, and you can see this yellowish kind of a lesion uh, just above the macula. And if you do a fluorescein angiography, you can see there is an cartwheel appearance, and there is a leak from early to late phase that shows that this is an CNV. But important thing here is you can see this CNV is away from the fovea. So 20% of the CNV are away from the fovea and you can do thermal laser. Please do not miss this CNV because you can give finite treatment to these patients. If we look at the OCT pictures, you will see a SRF subfoveal fluid here and then CNVM in this area. There is a large octa picture shows there is a large CNVM, and it's interesting that the octa shows a larger lesion as compared to the fluorescein angiography. So what we did in this patient, we gave one injection of ranibizumab and treated this extrafoveal lesion with the thermal laser. You can see day 30 picture, the fluid has almost disappeared, and day 60, you can see the laser has taken up, there is a scar here, there's no fluid on B scan overlay, and patient had a definite end to the treatment. Otherwise, you would, if you don't recognize this patient, you will keep on injecting throughout the life. Uh, these are pre-treatment OCT and post-treatment OCT. Coming to the subfoveal CNVM, where the major line of treatment is anti-VEGF. Uh, the regime what we usually follow is PRN regime, and that is you give 3 injections, and whenever the vision decreases, you go ahead and inject again. Uh, the most now from PRN regime, the main problem with PRN regime was we were losing vision in this patient, so we shifted to treat and extend in age-related macular degeneration. The basic concept of treat and extend is even if you don't have any SRF, then also you have to inject. That's very important. SRF is or intraretinal fluid is not mandatory in treat and extend regime. So you start with every 4 weekly, then if the fluid has dried up, you shift to 6 weeks injection at 6 weeks. Then you extend by another 8 weeks and you can extend till 12 weeks. Anytime, like if you are extending by 2 weeks and you find the SRF or the intraretinal fluid comes, like if the intraretinal fluid comes at 10 weeks, then you reduce the duration to 8 weeks. So now you keep on injecting at 8 weeks. This is one of the examples. You can see this is a subfoveal CNVM. There is a fluid here. You can see a yellowish white lesion here. And if we see we injected this patient and we followed this observe and extend. In injection one, you can see the fluid has gone. The injection third, the fluid has disappeared. These are octa pictures, and you can see here there is a CNVM. After one injection, the size of the CNVM has reduced. After the second injection, you can see again this CNVM has disappeared, and only you have the mature vessels. Uh, this is another patient. We started this patient on treat and observe, but now what happens? We started this patient with aflibercept, and uh, usually we were giving this patient injection at 6 week interval, but this patient became resistant to aflibercept or Eylea, and then after 3 weeks only, the patient used to get fluid or SRF with blurring of vision. We shifted this patient to brolucizumab, and with brolucizumab, we were able to treat and extend to 5 weeks. The moment patient comes to 6 weeks, he says, I have a blurring in vision, and he says, Ki you inject me, because he is only one night patient. And in this patient, I have given 26 injections of brolucizumab with no inflammatory reaction. Uh, if we see what is treat and extend, if you first start the treatment, then you go for an observe and extend, where there is a reduced number of injections as compared to treat and extend. If you look at uh, these on the left side, what you can see are the bars of PRN regime, and on the right side, these are the bars for treat and extend. The number of injections required in both the disease protocol were almost the same, and the vision improvement was almost the same. In number of visits were good, and if you see, the vision improvement was more in treat and extend in to 10 letters. This is one of the patient, a 39 years old male with came with defective vision, and we did an fluorescein angiography. You can see a leak here, suggestive it was a CSR. I observed this patient. Patient didn't improve, and did an EDI for this patient, and you can see a very thick choroid. So diagnose this patient as pachychoroid disease. And what Ritesh was talking, in which patient do you inject in cases of CSR? If you can label this patient as chronic CSR, after 3 months, you can give a stronger anti-VEGF, that is brolucizumab or aflibercept. Uh, Harbor study was one of the studies which was a 24-month efficacy and safety of zero point 0.5 milligram and 2 milligram of ranibizumab. Conclusions were that zero point 0.5 and 2 milligram of ranibizumab in CNVM number of injections and letter gain was same, meaning thereby there is no advantage of 2 milligram. In Lucas study, comparison of ranibizumab and bevacizumab for neovascular age-related macular degeneration according to Lucas and treat and extend protocol. If you look here, the number of injections required were 16 in ranibizumab group and 18.2 in bevacizumab group, and the later gain was almost same in both the treatment protocols. TREX study was a prospective trial of treat and extend versus monthly dosing of neovascular age-related macular degeneration, and they showed there was uh, a better gain in treat and extend, that is 10.5 letters, and there was a better drying of the disease. Uh, if we look at what is the pattern practiced world over, if you look in United States, treat and extend is the most preferred technique. In Europe, treat and extend and PRN regime is more prevalent. In India, treat and extend and PRN is equally followed. So to summarize, extrafoveal lesion should not be missed as early diagnosis and treatment can give finite results. Choice of anti-VEGF depends on type and subtype of lesions and financial status. Classic, occult or minimally classic lesions and RAP lesions, any anti-VEGF will do. PCV and pachychoroid spectrum, brolucizumab and aflibercept is the treatment of choice. Treat and extend regime gives the best results with optimization of the visit. Thank you very much.
So very good talk, Dr. Avninder. Uh, let's go brief and with what should a practitioner start with. So if you see a patient, what are the basic investigations which are required to start treatment? And then what is the drug you would start with?
So, if I have a patient of AMD, the basic treatment I'll do is an OCT, and at first sitting I'll also do a fluorescein angiography, because my follow-up will depend on the subsequent OCTs, and I'll not do subsequent fluorescein angiography. And if I have classified lesions as classical or type 2 or type 3 CNVM, then I'll go for any anti-VEGF. And but if I diagnose it as an PCV or a type 1 lesion, then I'll go for an brolucizumab or aflibercept.
Yeah, so it's a very good point. One is OCT is enough to start treatment. OCT angio, if you have, is good, but OCT angio is not mandatory. The CNVM seen on angio is not really what dictates your treatment in the future, because you may continue to see the same CNVM over multiple follow-ups, and it may remain quiet without treatment. So as of now, OCT angio is not is not important enough to guide treatment. It's okay to have information. And important is you can start with ranibizumab, but unless you have PCV with PEDs, pigment epithelial detachments, which requires aflibercept or brolucizumab, where ranibizumab doesn't work well, especially if there's also massive hemorrhage. Do we have time for more discussion?
No, just wanted to add one small point. A very basic thing which I started regularly doing now is fundus photograph for all these patients. Very important to pick up any fresh hemorrhages more than fluorescein angiography or OCT angiography. A good clinical examination fundus photo,
Yes,
it adds a lot more to our treatment decision rather than.
exactly. A hemorrhage or obvious elevation
Yes.
is much more important than anything. So clinical exam is of course irreplaceable.
Sir, what is your most commonly used regimen of all that you have discussed now, treat and expand versus PRN?
See, I start with observe and extend. Like if I have a treatment naive patient, 3 injections. If the lesion dries, then I go shift on to observe. And once the lesion bounce back, then I go in for an PRN kind of a regime. But many patients, I know ki after a period of time, I know when the recurrence is occurring. So many patients will come and tell me ki after 12 weeks they'll say ki, or after 10 weeks they'll see my vision has worsened. So in those patients, I follow treat and extend. So it's not that ki all patients go on treat and extend. Usually the chronic one which requires continuous inhibition of with anti-VEGF go to treat and extend. But 50% of my patients are on PRN regime.
And any experience of combining steroid for patients with PCV? Like some people say that you can combine steroids with anti-VEGF in these patients.
We were combining steroids when we were doing photodynamic therapy, but at the moment we are not doing
See,
any combination.
as a routine, it is not recommended. But there is an occasional case which will not respond to multiple aflibercept injections, and if you add a steroid, it will settle down immediately. So there can be an occasional case, and so we can use it as an additional armamentarium.
Thank you, sir.